Dr. Eletu, who is away in Ibadan, examining for West African College of Pediatrics. I also welcomed Dr. Fajolu, the moderator, and also the presenting team from EMEL Hospital, Dr. NGOZI, ULONNAM, and Dr. IBRAHIM, AMEEN, IKOYI. The topic for today, Necrotising Fascitis in Neonate. I think it's going to turn out to be a very interesting presentation. So if you know somebody who is sitting on the fence, please call them to join quickly. Without much ado, I will hand over to the moderator, Dr. Fajolu. But before I do that, let me welcome everyone who is present. You're always welcome. The meeting actually has been going on for about 1.5 years now. And as you have been told, the objective is for pediatricians in private practice and those who have interest in private practice to have a platform to share clinical experiences. We like to have more of case presentations, actual case presentations, and that's why today's presentation is special, because it is a case presentation where cases that have been managed are shared, and experiences of other people who may have had the same is sought, and a sort of peer review of the process takes place. So thank you very much. I now hand over to Dr. Fajolu, the moderator. You are welcome, everyone.
Thank you very much, sir. Good afternoon once again, everyone. You are welcome to this session of the PIPP seminars. Like Dr. Mobolaji Lawal has said, she's been going on for over a year now. So without wasting more time, we'll be going straight into the presentation. And this afternoon, we're going to be treated to a sumptuous meal, if I can say that, by two consultants who work at the EMEL hospital in FESTAC, and that's the Dr. Mobolaji Lawal's hospital. So this afternoon, we will have Dr. NGOZI, ULONNAM, and Dr. AMEEN, IKOYI, who are both consultants, like I said, treat us to
I guess we lost Dr. Fajolu there. Can you please unmute Dr. Fajolu? You are muted.
Okay, I'm back. So sorry. The internet is a bit unstable, so I just thought that I'll be able to do this to the end of this session. So, like I was saying, they're going to treat us to necrotising fasciitis, a case that they've managed in the hospital. So I'm going to hand over to Dr. ULONNAM, who will speak first. After that, Dr. AMEEN, IKOYI will present after, and Dr. ULONNAM will round up. So I'm just going to leave them to move on so that I won't interrupt. So after Dr. ULONNAM, we hand over to Dr. AMEEN, IKOYI, then you now come around, and then I'll come back again and then moderate the question and answers. Thank you very much. Over to you, Dr. ULONNAM.
Good afternoon, esteemed senior colleagues and colleagues. I would like to use this opportunity to thank the chairman of EMEL Hospitals, Dr. Femi Mobolaji Lawal, and the medical director, Dr. Leo Dudu, for granting us this opportunity to make this presentation. It's a pleasure to share with this erudite house our experience when we manage this particular neonate. And we would like to know what we could have done better, and we hope that all of us will benefit from this session. I'll be sharing my screen now. So my name is Dr. NGOZI, ULONNAM, and presents IN, a male neonate. He presented to us on the 10th day of life with a two-day history of fever, discoloration of the upper back, and excessive crying. Fever was high-grade, persistent, associated with excessive crying, poor feeding. He had an episode of vomiting. Mother notes that symptoms started just after the naming ceremony, which involved a large crowd of visitors. IN is a term neonate that was delivered via SVD following an uneventful pregnancy. Pregnancy was supervised. He weighed 3,000 grams at birth. And at presentation, he had had his BCG vaccine, the oral polio vaccine, and the hepatitis B vaccine. He was born into a polygamous family setting where the mother is the second wife. Baby is the second child of the union. So this is a picture of baby IN at presentation. This part shows the darkened, this is the dark area, and then we have the hyperemic edges around the dark area. So on examination, he was very ill looking and irritable. He was in so much pain, could hardly touch him. He was in respiratory distress, he was febrile, there was no pallor. Vital signs on presentation, he had a heart rate of 140 beats per minute, had a respiration rate of 77 cycles per minute. Oxygen saturation was 94% in room air. He had fever with temperature 38.5 degrees centigrade. His chest was clear clinically. On the musculoskeletal system examination, there was hyperpigmentation of the upper back, measuring about 5 by 4 centimeters with hyperemic edges that were not raised, and it was exquisitely tender. For the central nervous system, he was irritable. He was, the tone and reflexes were normal. So we asked ourselves, what was the etiologic diagnosis? So we made an assessment of neonatal sepsis to keep in view non-accidental injury. It was because of the severity of the findings on musculoskeletal system examination and the exquisite tenderness. So the full blood count results at presentation, that was what we got. The packed cell volume was 43%, white blood cell count was 3,100. And then we had elevated ESR of 45 millimeter in the first hour. RVD screen was negative. We did the EUCR, electrolyte urea and creatinine, and that was the result we got. We admitted him into our neonatal intensive care unit and commenced him on IV antibiotics. We started him on IV meropenem and IV vancomycin and IV fluids. We requested an X-ray 2 days later as he had cough. And the X-ray showed patchy opacities in both lung fields. Cardiac size was normal, and the report was suggestive of a bronchopneumonia. By the 3rd day of admission, the affected area became soft and fluctuant, necessitating an incision and drainage. And we drained 30 mL of mucopurulent fluid, and we sent that for microscopic culture and sensitivity. We made a diagnosis of neonatal sepsis with pyomyositis of the upper back. By the 5th day of admission, the wound was still progressing despite the antibiotics. We invited the bones and plastic surgeon for review, and the wound examination at this point showed necrotic skin over the mid-upper back, measuring 10 by 6 cm in the widest dimension, with surrounding hyperemic edges, extending the wound to 14 by 10 centimeter. Edges are undermined, and there was slough at the base of the ulcer. At this point, we made a diagnosis of necrotizing fasciitis of the upper back. He had a bedside debridement and was scheduled for a formal debridement. He was placed on daily dressing with normal saline and honey. So these are the pictures of IN. This picture was the picture after the bedside debridement, showing a lot of necrotic tissue, necrotic fat, necrotic tissue. And then this was the picture after the formal debridement. And then this was the picture by the 12th day of admission. So the blood culture results that we got about 7 days after showed light growth of coliforms, sensitive to fluoroquinolones and resistant to other antibiotics. The post-MCS didn't help, there was no growth. So the initial antibiotics we started, we discontinued them and started him on IV levofloxacin. In the first week, he had fluctuating pyrexia within the range of 37 to 39 degrees centigrade. There was no period when he was afebrile in the first week. Repeat full blood count at this time showed them PCV29 that dropped from 43%, and then the white blood cell count had increased from 3,000 to 13,000. And then he was transfused with packed cells at this time, and then had a post-transfusion PCV of 35% 2 days later. By the 2nd week of admission, he developed very distressing cough occurring in bouts. And then we had another X-ray done that showed diffuse near homogeneous opacities at the mid and upper zones of both lung fields, more on the right. Cardiac size, bony thorax appeared normal, and it was suggestive of pulmonary tuberculosis to rule out COVID-19. That was 2020 period, 2020-2021. So the child was noticed to have tachycardia and was pale. A PCV at this time was 24%, and he received another blood transfusion. So these are the X-rays that were done. This one marked as one was the first one we did within the second day of presentation. We showed some opacities here, but by this one we did by the second week, the opacities had increased. You can see them was much worse than the previous one. So it was actually worse than when it came. At this point, we had to take further history from the mother. And then we found out that the mother was treated for tuberculosis in 2006. That was 15 years ago. And she wasn't compliant with treatment. And she required a retreatment in 2013. She did a chest x-ray in 2018 that was still suggestive of a chest infection. We did x-rays for other members of the household, and they were all normal. We took samples of the baby, stool samples for gene experts. Result was negative. However, we commenced baby iron on anti-cox therapy. We used the combination rifampicin, isoniazid, pyrazinamide, half tablet of that and half tablet of ethambutol for the intensive phase of 2 months, and rifampicin and isoniazid for half tablet of that for the 4 months continuation phase. That was as per the national guidelines for tuberculosis management. Baby made significant clinical improvements, and there was prompt resolution of the cough. The wound healing became progressive and rapid. Mother was counseled to have a wound graft, but she declined based on financial, she was paying from pocket. After 25 days of admission and 10 days on anti-cox, he was discharged to continue wound dressing on outpatient basis and to complete his anti-cox therapy. Baby Ian made very good clinical recovery, and we encouraged the mother to have a re-evaluation for tuberculosis. So this was baby Ian on the day of discharge, and then it's a picture about a month after. This is his present day picture. This was 2 years after treatment, and the wound has healed totally. So we asked ourselves, was this actually tuberculosis? So at this point, I will hand over to Dr. AMEEN to continue the literature review, and then I'll be back to summarize. Thank you.
Good afternoon, everyone. I would like to adopt the already existing protocol. So my name is Dr. IKOYI IBRAHIM. So I'll be taking it up from where my colleague stopped, which is the question we asked ourselves. So was it TB that this child had? So I believe at the end of the presentation, we'll be able to answer this question. So I'll be taking us through tuberculosis in the neonates. I'll be using this outline. So by way of introduction, tuberculosis is one of the leading infectious diseases worldwide, and it's still a serious public health problem in many countries like ours. And World Health Organization estimates that 1/3 of the population is infected with tuberculosis, and the infection rate increases by nearly 1% every year. Tuberculosis in the neonatal period can classically be divided into two, which is the congenital type and the postnatally acquired type. The congenital tuberculosis is caused by Mycobacterium tuberculosis, which is acquired around during pregnancy and around delivery period. And necrotizing fasciitis, on the other hand, is a rapidly progressive infection of a deep fissure with secondary necrosis of the skin. So, and low immunity is one of the major predisposing factors for having necrotizing fasciitis, in which a neonate is also considered to have a low immunity, as we know that neonates have their immune system is still developing, and they have low quantity of immune cells, and also the quality of those immune cells are also are still developing. Okay, so they are also categorized as having low immunity. So they are therefore predisposed to having this necrotizing fasciitis. However, necrotizing fasciitis secondary to tuberculosis is rare, but some cases have been reported in the adult population by FESTAC et al. And Co et al. Congenital tuberculosis is a rare complication of in utero tuberculosis infection in the mother through hematogenous spread. And diagnosis of this condition is really difficult as a result of the non-specific symptoms, and also the fact that most of the time their mothers are usually asymptomatic. So therefore leading to underreporting of this condition. However, globally, about 500 cases have been reported. About 358 cases of these 500 were reported before 1995, and 110 cases were reported between 1996 to 2009, and up to 2017, there were 21 cases that were reported. Satya Kumar et al., Airede, Orogade et al., and Peter Side et al. Have all reported cases of congenital tuberculosis in Nigerian units. Congenital tuberculosis is estimated to be about 2% in countries with high volume of tuberculosis. And mortality can be as high as 50%, which are mostly due to delay in diagnosis and delay in treatment. So by way of pathogenesis, the mode of acquisition of congenital infection is assumed to be due to maternal bacillemia transmitted to the placenta, amniotic fluid, and the maternal genital tract. So what happens during uterine life is that there is dissemination of this tubercle bacilli in the maternal serum. So there is also dissemination to the placenta, and the primary means by which it infects the fetus is via transportation of this organism through the umbilical vein to the hepatic liver. So from the hepatic liver, it forms the primary complex in the liver. And from there, it can involve the perihepatic lymph nodes and can secondarily infect the lungs of the fetus. However, during fetal life, the symptoms are usually, the fetus usually doesn't manifest symptoms because of the reduced oxygenation. But after birth, exposure to more oxygenation and improved pulmonary circulation can reactivate these complexes in the fetus, and they tend to manifest the symptoms after that. So another pathway in which a fetus can also acquire this organism is when the tubercle bacilli in the placenta ruptures into the amniotic fluid, and the fetus ingests and aspirates this tubercle bacilli. So that can lead to formation of the pulmonary the complexes in the lungs, and also the complexes in the GI tract, bypassing that of the liver. So some patients may actually not manifest, the complexes may actually not be in the liver, like the case in our index patients. Our index patient presented with mostly pulmonary symptoms, and there was little or no GI symptoms in our patient. So clinical features averagely will occur on the 24th day of life. However, it can range from 1 to 84 days, which is about 12 weeks. Then mothers, apart from the other symptoms of tuberculosis like cough, weight loss, excessive night sweats, they can also have infertility and recurrent stillbirth, which is actually one of the reasons why the condition can actually be very rare, because many of the mothers that were supposed to maybe give birth to patients that have congenital TB, as a result of their status, may actually not be able to deliver. So, and that might lead to the rarity of the condition. So, but in the fetus, when they are eventually born, they can have intrauterine growth retardation. Some of them can present with low birth weights, poor feeding, fever, irritability, failure to thrive, failure to gain weight, cough, respiratory distress, as some of these were also seen in our index case. Some patients may also present with hepatosplenomegaly, splenomegaly lymphadenopathy, and abdominal distension. Some symptoms may also include lethargy, jaundice, ascites, otitis media, with or without mastoiditis. Can also have involvement of the parotid glands, osteomyelitis, paravertebral abscess, cold abscess, and rarely it can involve the skin, where they have papular and pustular skin lesions. Singh and other authors have actually described some clinical scenarios whereby the diagnosis of tuberculosis should be considered in a unit. Number one of that is where a newborn infant, mainly from an endemic area, is unresponsive to conventional treatment for worsening pneumonia. So such a condition, you should consider the diagnosis of tuberculosis. If the mother was labeled to have TB and baby has no specific signs of TB, CSF analysis with high lymphocyte count and no identifiable bacterial pathogen, or where a baby has fever with hepatic and splenic enlargement. Such conditions should raise suspicion of tuberculosis. Diagnosis is often very challenging as a result of the unspecific clinical features and the fact that many of these mothers usually are asymptomatic. So it is really it's only when you think of it that you would be able to make the diagnosis. Okay, so high index of suspicion is very, very key in the diagnosis of congenital tuberculosis. Diagnosis often involves screening of the pregnant mothers. Okay, so it's important to screen these mothers at the slightest suspicion of tuberculosis by taking adequate history, cough, excessive night sweats, weight loss. That should lead to further screening with tuberculin skin test or even checks in X-ray, as the case may be, to identify tuberculosis in the mothers. And when the neonates are eventually born, appropriate samples should be taken for microscopy, culture. Samples like gastric aspirates could be taken. You could also take CSF, peritoneal fluid, pleural aspirates, as the case may be. Some patients may need mechanical ventilation, so we could go ahead to take tracheal aspirates to culture this organism. And we could also do bronchoalveolar lavage to do a polymerase chain reaction to identify this organism. And some cases may need to go ahead to do liver or lymph node biopsy to identify this the typical caseous granuloma in tuberculosis. Other ancillary investigations that you want to do include full blood counts, C-reactive protein, ESR, which may be elevated. Liver function test could also be deranged. HIV screening is also important to rule out other causes of immunosuppression. The imaging, like we showcased in our index case where the patient had patchy opacities that was worsening despite the use of isolating antibiotics. So chest X-ray is also very important. Abdominal ultrasound is very key to identify this fetal, the hepatic primary complex that we talked about earlier. Cantwell in 1994 suggested criteria for diagnosing congenital TB as against postnatally acquired tuberculosis. And he has described the major criterion and other minor criteria. So the major criterion is that there must be a proven TB lesion which should be present in the infant and at least one of the minor criteria. So the minor criteria includes lesion that occur in the first week of life, caseating granuloma or primary complex in the liver, either by biopsy or by identifying that using the abdominal ultrasound. Then TB infection of the placenta or maternal genital tract, or one is able to rule out postnatal transmission by screening the family of the patients or the health workers to be able to be sure that the mode of transmission was not after delivery of that child. Okay, so in our index case, we were able to identify a primary, the suspected primary lesion of TB as a result of the chest X-ray that we showed, which was a few patchy opacities initially, but after about 1 week, it became worsened. Despite the use of antibiotics, potent antibiotics, the child still had these worsening signs of chest, on the chest X-ray, and the fact that the patient also had the symptom on the first week of life. Then we were also able to screen some family members to rule out other possible routes of transmission. By way of differential diagnosis, like I've said earlier on, the symptoms are usually very non-specific. So you need to think about TB to really make that diagnosis of TB. Okay, so one of the mimickers of TB is congenital pneumonia, which can occur shortly after birth in the neonates. Presents with similar symptoms, cough, worsening respiration, hypoxemia. So that can be acquired if the fetus actually aspirates an infected amniotic fluid during the process of delivery. Okay, so infection with maternal genital tract organisms, normal commensals of the maternal genital tract, like some other gram-negative organisms, and also group B streptococcus. Okay, so this patient might manifest all the symptoms. Chest X-ray may also show patchy opacities in the lungs, as it is in the in congenital tuberculosis. However, blood culture would likely showcase the possible organism, and they are also likely to respond to conventional antibiotics as against the case in tuberculosis. Neonatal sepsis, the same way, manifests with non-specific symptoms like tuberculosis. However, they are likely to do well on conventional drugs. Prematurity, the patients are usually born before 37 weeks of life. Okay, so they are also likely to respond to normal anticipatory care of prematurity. Touches infection, which are infections that can be acquired during pregnancy, and such mothers can have the issue of febrile illness and rash during the first trimester of pregnancy. And when the babies are born, the baby can have some malformations. They can have microcephaly, they have hydrocephaly, and some brain imaging can actually show intracranial calcifications, like in the case of toxoplasmosis cytomegalovirus. Okay, so and serology might give the diagnosis away because serology might show positive hemoglobin M serology, or even worsening or elevated or increasing levels of hemoglobin G antibodies. Okay, so lastly, disseminated BCG disease is also one of the mimickers. But in this case, the patients are usually they will have received BCG, and most of the time they usually manifest with local signs, in the sense that the symptoms are more around the point of vaccination. They have erythema swelling around that area, and they are also likely to have more lymph node involvement as against congenital tuberculosis, which is more disseminated. So treatment is always advocated as early as possible, and as it is said that congenital TB is always fatal if left untreated. So it has also been said that the risk of not treating is more than the risk that you get when you give the drugs from side effects of the drug. So treatment should therefore begin as soon as diagnosis is suspected, and the treatment is same as you give in older children and adults. It involves the use of 4 drugs for the first 2 months, like we did in our index case, by using isoniazid, rifampicin, parazinamide, and streptomycin, or ethambutol in the first 2 months. And one can actually should actually extend the treatment with isoniazid and rifampicin for 4 to 10 months, depending on the severity of the disease. Okay, so if the patient has biliary tuberculosis or has bone involvement, in such situation, one is expected to extend it for a longer period for up to 10 months after the first intensive phase. Ethambutol is typically avoided due to its risk of ocular complication, which may be difficult to monitor in children. Prevention, I will be focusing more on the specific protection, which involves the use of isoniazid prophylaxis, and it is indicated for mothers with tuberculosis that have received treatment for less than 2 weeks. Also, in those of them that have received for more than 2 weeks, but they still show smear positivity. And American Academy of Pediatrics have actually advocated that all units of mothers with tuberculosis diagnosis after birth should also receive isoniazid prophylaxis. And the duration of prophylaxis is at least 3 months, guided by tuberculosis tuberculin skin test. Okay, so if the patient has been on isoniazid prophylaxis for 3 months and the TST is showing positive results, such a patient should receive it for a longer period, for up to 6 months, until the TST is negative. And if the TST is positive and there's evidence of active infection, evidence maybe on chest X-ray or other modalities, such patients should commence antituberculous therapy. BCG vaccine is very key in prevention. It is not recommended for congenital tuberculosis. In our index case, the child received BCG vaccine and still had a full-blown features that were suggestive of tuberculosis. Okay, so this is also further buttressing the fact that this patient must have or may have acquired this infection in utero before the vaccine was even given in the first place. So indication for BCG is actually indicated in neonates receiving isoniazid prophylaxis. However, the vaccine should be given after the TST is negative. Okay, so you continue giving the isoniazid prophylaxis until TST is negative. So after that, you then give the BCG vaccine. In conclusion, congenital tuberculosis is a rare disease with a high mortality. Early detection is challenging because of the non-specific nature of the signs and symptoms of tuberculosis. during the pregnancy period and infantile period. Prompt identification and proper treatment regimen for congenital tuberculosis strongly correlates with good outcomes. So we're recommending that it is necessary to consider congenital tuberculosis in differential diagnosis of neonatal or pulmonary infections in infants, especially in countries where the incidence of tuberculosis is of high burden, and also when we have used potent conventional drugs and they are not yielding results. So such diagnosis should be considered. And we also recommend that screening of tuberculosis should be incorporated into the routine prenatal care at the slightest suspicion of tuberculosis. These are our references. Thank you all for listening. So at this juncture, I would like to call on Dr. ULONNAM to wrap up the presentation. Thank you.
Thank you, everyone, for your patience. And then in summary, we have presented IN, a neonate who had features suggestive of congenital tuberculosis. Initial diagnosis was masqueraded by the necrotizing fasciitis. And it was key to note that clinical improvement started when anti-cox therapy was commenced. He has done very well. Thank you very much.
Thank you very much, Dr. ULONNAM and Dr. AMEEN IKOYI, for that excellent presentation. I was being thrown in and out of the meeting, so I missed some of your presentations. So at a point, I was wondering, was it congenital TB or necrotizing fasciitis that we're talking about? But Dr. ULONNAM's wrap-up has cleared that for me. So we'll move on to question and answers now. So the floor is open for us. If you have any questions, and we raise up our hands, our electronic hands, so that you can be called. Or if you have any that you want to write in the chat box. There's nothing written in the chat box for now. So please, if you raise up your hand, if you have any questions or comments. Okay, I have a Galaxy A71 5G. I don't know who that is. Please, can you unmute and introduce yourself, please, and go ahead with your question. Galaxy A71 5G.
I don't know. I cannot be heard.
Okay, yes, we can hear you. Go ahead.
Okay. Dr. Egejuru is my name. Dr. Egejuru is my name.
Good afternoon, sir.
Good afternoon, ma. Dr. Egejuru is my name. I can be heard, right?
Yes, please.
Well, I immensely thank the team for presenting this very rare case, and we're all learning every day. But I want to make some suggestions. One, we've been warned about the use of antibiotics, the inappropriate use of antibiotics. You know, that would have been no reason starting this start on recommend as the first line of choice of antibiotics. Are we hearing me?
Yes.
Yes, you can hear you.
Yes, I mean, there would have been no need starting this start on recommend as the first line of antibiotic therapy. Number two, could this okay, we didn't isolate tuberculosis, mycobacterial tuberculosis. We didn't isolate it. So it was a therapeutic trial. It was a therapeutic trial that gave us a positive response that we're now saying it is TB, or it was TB. Am I right? We did not identify the organism.
Yes, that's right.
Yeah, so it was a therapeutic trial. Okay, now is it possible? Well, I agree it was TB. Is it possible that it could be any other anaerobic organism, any other anaerobic organism that could present this way? Well, there's the need for therapeutic trial is good, but we didn't isolate. We just got a family, secondarily, on second thought, we got a family history that pointed to the primary source. But could we have been dealing with another type of mycoplasma organism or another type of anaerobic organism that could still be responsive to the drugs we gave?
Thank you, sir.
And number three, I like making fun. I like making fun at times. That thing is, you do debris called debris
Yes.
on a lighter mood. Debris the bad news. That word is German. So we did a debris. The doctor who presented, are you listening?
Yes, I'm taking notes.
Yes,
sir.
it's debris. Just like most doctors make a mistake about pronouncing Vidal, Widal. It's called Vidal because it's also German. Some will say Widal, some will say it's Vidal. Just like this is debris. So we would have been treating any other case apart from TB. But we are justified in this case because that's a focal point. That's a.
Thank you very much, sir. Dr.
Yes.
ULONNAM.
Yeah. Thank you.
Thank you very much, sir. Please take note of the questions so that you can answer them together. I have a question, and I think it's still in line with what Dr. Getru has said. Because when he started the presentation and the picture of that baby that he showed with the back reminded me of one of our patients that we had some time back in the unit. So this child had asphyxia, did not cry at birth, and was beaten in inverted commas as a form of resuscitation. So that baby was blue-black all the way down from the neck all the way to the foot or to the feet. And of course, he ended up with having to have an I&D done and all that. So that was what crossed my mind initially. Was there any history of this baby not crying at birth? And what form of resuscitation did the child have? That is one. Then also with this diagnosis of congenital TB, remember that the drugs used for treating TB are all antibiotics, and there's potent antibiotics. And if this was another organism which is not TB, you might have responded to these antibiotics. So, and towards the tail end, I heard you say something about encourage mother to screen more for TB or something like that. So did we find anything incriminating in terms of, regarding TB with the mother, for us to now make that the diagnosis of congenital tuberculosis in this child? The chest X-ray, the child was asphyxiated, has an infection, it can have a congenital pneumonia that may be difficult to treat. Also note that the X-ray changes following treatment of pneumonia or resolution also don't come so fast. So you may still have some capacities and all that in the lung fields, even after a week of your antibiotics. So those are my comments and questions for you. Let me see if there's any other answer. Any other comments or questions for the presenters? Then also, you said you isolated an organism, if I got you right. I'm not sure. What was the organism sensitivity pattern for that organism that you isolated? I can't see any other hand up. So you can go ahead and answer these questions. Maybe others are thinking about their comments and their questions. And if I see any other hand up, I'll recognize that person. Dr. ULONNAM and Dr. IKOYI, you can go ahead and answer or respond to the comments and the questions.
Thank you very much for the comments and the questions. For the antibiotic use, we used high-severity antibiotics because we felt the child had severe neonatal sepsis. We felt it was hit or miss. We felt that we had to go that direction according to our protocol for severe neonatal sepsis. Yes, so we did not isolate Mycobacterium tuberculosis, so we did a therapeutic trial.
Sorry, what antibiotic did you say? What antibiotic?
We started him on IV meropenem and IV vancomycin.
Okay, okay.
So it could have been any other anaerobe. It could have been it's possible, but our culture grew coliforms that was sensitive to fluoroquinolones, and we had to change to fluoroquinolones before we started the therapeutic trial of antipodes. There was no history of the baby not crying at birth at all. Baby cried at birth and had no need for any resuscitation. So it couldn't have been trauma. And as the X-ray changes, it's possible that it could have been congenital pneumonia, and then the resolution doesn't come out so fast. But we just felt that with the history of the maternal tuberculosis, her poor compliance, requiring retreatment, and an X-ray that still showed tuberculosis at 2013. We felt that was in keeping with the possibility of congenital TB. So it's very possible that the combination of the antibiotics helped the baby to recover. We felt that because of that history, and then the baby's clinical presentation, and then the prompt resolution with antibiotics, it's likely it's not, we don't have any other proof, but it's likely to be congenital tuberculosis. Thank you.
Thank you, Dr. ULONNAM. So somebody has written in the chat box asking that, thank you for your presentation. What are the routine prenatal screening that you suggest? What routine prenatal screening do you suggest? Did you hear that?
Routine prenatal screening.
Did you hear that?
Yes, routine prenatal screening. Okay. Okay. So for the mother, what we suggest, a history will be very critical. We want to know, has she had tuberculosis in the past during antenatal visit? Has she had TB in the past? If she has had TB, how is she now? Does she have a cough now? If she has symptoms, then we need to do tuberculin skin tests. If she's symptomatic, we also need to do, we can't expose her to X-rays, but the screening will be based on her history. Basically, we tailor it down to her history. Tuberculin skin test, gene experts, if symptoms are suggestive. We won't do it routinely. It will be based on the clinical presentation and the history of the mother. Thank you.
Somebody is also asking what the HIV status of the mother was.
Okay, the mother's HIV status was negative. She was negative. Baby was negative as well.
And another question is, how did you interpret the skin lesion? So if this was congenital TB, why was this child presenting first as that skin necrotizing fasciitis?
I didn't get the question.
Do you think it was TB? How did you marry the TB, congenital TB, and the necrotizing fasciitis. I missed some of your presentation because the internet kept taking in and out, so I'm sorry.
Okay. What we could have done was to do a histology, a biopsy of the wound and send it for histology. It could have shown us some form of caseous necrosis that would now make us think more of tuberculosis of the skin. But this was what baby had complications, neonatal fasciitis and a congenital TB, a chest infection. So it's not clear to say that they were all together. We're not 100% certain that they all came in together.
How long did you give the immunolones that the organism was sensitive to? How long did you give it for?
We gave it for about 7 days before we started the anti-TB trial.
And there was no improvement at all. Okay, so I have another question here. Somebody from Dr. Shelley from UPTH is saying, thank you for the presentation. Can staphylococcal scalded skin syndrome be a differential? If yes, what would have been done differently? Second question, it just makes sense. Why prematurity as a differential diagnosis of congenital TB? That's from Professor Augusta, and the topic was necrotizing fasciitis, and we ended up discussing congenital TB. Those are my thoughts too. What was the link? Was mycobacteria isolated from the wound? Those are the two questions currently on the chat box for you.
So for the first question, could it have been SSS, staphylococcal scalded skin syndrome? Not likely, because the clinical presentation would have been more superficial than in our patients. Our patient had very deep-seated skin infections. We could have started with, it could have been part of the necrotizing fasciitis has a polymicrobial etiology. It could have been one of the organisms that caused it, but the picture was deeper than SSS. That's from our own observation. And then okay, the second question about what made it congenital TB and why we're discussing necrotizing fasciitis and congenital TB. Yes, we brought it out because we actually couldn't find a link, but we found these two conditions in this patient, and we decided to bring it to the house for this discussion. Then prematurity as a differential of congenital TB. Yes, in premature neonates, we have increased incidence of neonatal sepsis that can present as congenital pneumonia. So you could actually have this at the back of your mind. Your history too would tailor your diagnosis. It's actually a differential because the chest X-ray findings will be similar to X-ray findings in congenital TB as well. At this point, I want to thank my teachers. I can see some of my teachers here. I can see Professor Onyire Namdi, my teacher in Ebonyi State then. Thank you very much for your participation, sir. I want to thank Dr. Fajolu, my teacher in Lutz, not just my teacher, but more like my mother. She was very caring and then took care of my emotional and psychological needs during residency training. Thank you very much, ma'am. My pleasure. And every other of my senior colleagues, thank you for your presence today. I'm very grateful.
Thank you very much, Dr. ULONNAM. I think that I took care of the emotional needs. I hope I didn't make them worse.
Oh, ma'am.
Okay. Dr. Henry saying this educational webinar from the private sector is very commendable. How often do you organize this? So to answer that, it's done every month. Every last Thursday of the month it is done, and the notice is circulated on all the different platforms, WhatsApp platforms that we have. Kindly continue to share links for future presentations. Okay, so if you're on the NISON platform, it's usually shared there. I know that for sure. Last Thursday of every month, somebody, Dr. Oletu has answered that. Dr. Oletu is back, so maybe I cannot do that. Anyway, so this is, I think those are the main comments and questions, and thank you very much once again, Dr. ULONNAM and Dr. IKOYI, and also the entirety of the EMEL hospital which is chaired by our dear Dr. Femi Mobolaji. We say a very big thank you to you. And the presentation will be shared later. I'm not sure the person who was asking for the link to be shared. I hope you are on one of the platforms, but if you are not on, then you can ask Dr. Eletu to please send to you on your own personal WhatsApp platform. Thank you very much. So I'm going to hand over to Dr. Shaka to round up. I don't know if Dr. Mobolaji, one of the two, still has some more comments. Thank you very much, everyone.
Well, thank you everyone for being part of this meeting. I believe it's been very useful and very thoughtful. For the person who actually asked for information about how to be part of this, what I would suggest, if you can private chat GIPPD, the host, and share your contact, I'm sure they will be kind enough to add you to the WhatsApp group of the private personal group. So what you need to do, direct message to the host, GPIPP, your number, your details, and I'm sure we'll put you in the link so that you can get notification every time we're having this. Like was mentioned, is every last Thursday of the month and been running for over 18 months. I believe we've had a very useful meeting today. And like was also posted on the platform. Sorry, there's something. Okay, somebody has put, I'm not on any platform, please, can I get permission via email? So we've noticed, so what we'll do, we'll copy your email and then we'll send a mail to you. Say I'm not on any platform, that's Joshua Alex. So I'm sure that's doable. So I'm sure the host will be able to do that, to share the information with you. I just also say to you that the recording of this meeting will be on YouTube and of other prior meetings we've had. So you can still go back to our YouTube channel to refresh or to listen to past edition, which is a very good resource that you can use for education, and you can share with also resident doctors or people in your network, and I'm sure we can learn together and go together. I will ask Chairman if he has any closing thoughts before I finally close the meeting. Dr. Femi Mobolaji, closing thoughts, please, sir.
Thank you very much. I would just like to thank the presenters very much, the ML team, for plucking the courage to present this case. Especially as it was a challenging case. Everything was not, was not very clear altogether. And it is one of the main objectives of this platform, which is to encourage pediatricians in private practice to present actual clinical experiences to peers, so that peers can learn one or two things from it. And more importantly, if there are one or two suggestions that they can pick out where things can be done better in future. The whole essence is that the clinical skills of pediatricians in private practice must be constantly sharpened so that it can get better. I'm very, very pleased today for the presentation and for the comments we have seen. And I want to encourage everyone, especially those in private practice, to come up and present cases. It doesn't matter how challenging, and it doesn't matter how simple or how complicated. Because when we started this group, why we started this group was that we observed that when people go into private practice, they get isolated and they don't share experiences with other pediatricians far and wide, except if they are lucky, they have a few people in their group. And in that way, any skill that you have acquired, which you don't constantly update and apply, you may begin to lose part of them as time goes on. So I'm very happy that the essence of this meeting has caught on and that more people are getting interested in it. We try to choose our topics very, very carefully. And on this note, I want to note that our coordinator, Dr. Eletu, is out in Ibadan conducting West African exam. Only recently was he invited to become an examiner from private practice. And I have no doubt in my mind that it is largely a consequence of his activities in this group. So I want to encourage other people to show interest in this group, help us to plan, to coordinate these programs, and through that process, your own clinical and other skills will be further strengthened, and you'll be better placed to contribute more towards pediatric training, either in your small corner or even in the general or teaching hospitals where you may find yourself, and also pediatric education as the case may be. Especially, there are many of us who have subspecialty training, who find themselves in private practice, where arguably you may not see enough cases to justify the years spent for your subspecialty training. We should come out and be ready to share our experiences and interact more with people who are in the real academic setting, such that we are better positioned to give service where it is necessary. So I'm very happy for today. I'm very happy for the progress we have made. I thank the presenter again. I thank Dr. Fajolu for moderating, and also Dr. Dushote for always coming in, standing in for Dr. Eleto. Thank you everyone for attending. It's been a very good day. Over to you, Dr. Dushote.
Well, thank you, sir, for wrapping up very nicely for all of us. What I need to say is to thank everyone for joining the platform. Without you being here, we'll just be talking to the air. But thank you for coming. And please spread the word. Invite other people. It's been very educative. It's very interesting. And we believe this will grow in leaps and bounds. So our next meeting will be next month, last Thursday of next month, in the month of April. We're looking forward to a more robust and challenging presentation. So like I said, the recording will be shared on some of the WhatsApp platform that we have. And then you can also check out our YouTube channels. You can listen to this edition and other previous editions. So thank you everyone for joining, and God bless. Enjoy the rest of your evening.
Thank you very much, Dr. Dushote, and thank you, everyone.
Thank you. Thank you, everyone. Congrats, Augusta, for this. I think I'm sure you are smiling.
Thank you, sir. And well done.
Well done.
You came to the rescue by taking the bull by the horn. Thank you, sir.